I'm going to be moderating a panel discussion. I'd like to ask my fellow panelists to come on up here. Mark and Jerry and George, can you come on up? We're going to start out with some questions that were submitted by the audience, either previously to the meeting or online or through today's. And not surprisingly, a whole bunch of these, or a high percentage of these, are aimed at Dr. Chambers. But we'll encourage all the panel members to contribute, and we'll try and have both a question and answer and discussion session here. Okay, to start it off, to support the use of a single active arm in I think in a vehicle-controlled study, I think is what they meant to say here, phase 3 study, what does the FDA look for in phase 2, i.e. sample size, p-values, et cetera? And does this thinking in dry eye differ from the thinking in other diseases like wet AMD or IOP lowering?
The typical expectation in phase 2 is that you will eliminate from the range of possible concentrations, bring it down to either 1 or 2 or 3 at most concentrations, and say this is what you should be confirming in your phase 3 trials. So we don't have any particular numbers in mind, as long as you can show a rationale for coming up with the dose selection that you do. And so that's, from my perspective, the goal of phase 2 is to try and narrow down the dose range by whatever numbers that it takes to be able to do that. It doesn't require statistical significance. It's just you're giving a rationale for your dose ranges.
And typically, do you get to a single, is it possible to get to a single dose that is acceptable to run your phase 3, or you more typically see several doses in the phase 3 studies?
It varies tremendously. If there's a clear dose response, then you can pick out one dose. If there is not, and that is not uncommon, as you mentioned in your talk, then you end up with, not uncommonly, 2 doses that are the best 2 that have been identified to date.